Hello and very good morning, everyone. So, welcome to Unacademy. So, let's get NEET PG. Myself, Dr. Muskan Chaudhary, and we will discuss today about some leftover the miscellaneous viruses, and we'll do the question answer round for that. So, starting with Unacademy, Unacademy is the India's largest learning platform where you get access to both the live and the recorded sessions, and you will be able to access the recorded class anytime and anywhere, personalizing your learning experience from the topmost educator for any medical examination, be it NEET PG or UG, competing in the live T&Ds and testing our preparation with highly competitive quizzes, and studying on the device of our choice, and watching our classes on the bigger screen, assessing up to 25,000 of the MCQs with high yield clinical questions with effective explanations with printed and digital notes that are being provided by the Unacademy, and you will be able to access our recorded classes anytime and anywhere. Now, under iconic subscriptions, Unacademy and Prep has come together. We will get access to all clinical integrated essentials with video lecture, QBanks, rapid revision snapshots, and dream notes. With well-structured live classes, recorded sessions, QBanks, completed T&Ds, and the printed digital notes by the Unacademy. Under the NEET PG Plus category, for 2 years it is around 36,000. For 24 months, that is costing us around 1,500 per month, and 1,250 for 3 years and 1,625 per month for 18 months. And iconic, it is for 2 years, it is around 58,500. That is for 3 years, it is 1,875 per month, 2,438 for 2 years, and for 18 months it's 2,875. And what is the subscription, that is around 58,500. And please do use my code, that is Muskan 10, to get 10% of the discount. Raise a hand feature where you can raise your hand, ask your doubts from and the queries from your educators, and that too within the live one-on-one interaction with your favorite educator, so that you can solve your doubts within the class itself. So special class features includes the interactive live classes. Attending the live class, participating in the live class gets a doubt clear to the polling for the learners. Raise a hand, talk to educator, and get your doubts resolved all in the real time. Never miss a class because you will get the notification for the same, and all the upcoming classes, you will be notified before the class. Uh, Download the lecture notes from the Unacademy as well as from the Telegram, and revisit the important topics that you think you are weak at, and anytime and anywhere. So we'll start with the first virus of the today. That is very important one. That is the rotavirus. Now, rotavirus belonging to the family that is Reoviridae, and it is very important. The structure is very important. It has a wheel-like short spikes, which gives it a wheel-like structure. It possesses a segmented RNA. If you remember, Bohr was the mnemonic for the segmented RNA, Borneo orthomyxovirus, and R was here. That was the Reoviridae, that was the rotavirus. Serotypes A to G, most common serotype is group A, and adult rotavirus strains belong to the group B. Commonest cause of the diarrhea in infants and the children. So this is very important. It is a common cause of the diarrhea in the infants and children. The commonest cause for the viral diarrhea in the infants and the children. And seasonal variation, that is the most common in the winter with the fecal-oral route, and incubation around 2 to 3 days. So that is it about the rotavirus, important one, that is belong to the family Reoviridae, and it has a wheel-like structure, most common cause for the diarrhea in the infants and the children, with most common seasonal variation in the winter with incubation period of 3 days, and route is fecal-oral route. Then we come to the lab diagnosis. Now, lab diagnosis is by the electron microscopy. Detection limit is 10 is to 6 particles per ml. Now, ELISA detection technique and the culture is difficult because rolling of the tissue culture facilitates growth, and another is the RT-PCR. So we use the ELISA, we use the RT-PCR and electron microscope. So this is the structure of the rotavirus, that is showing the typical wheel-like structure, and you can easily see they are what segmented. Now, cause of the viral gastroenteritis, rotavirus is the most common cause or the gastroenteritis. Other than this, we have the enteric adenovirus type 40 and the 41. We have the very important one that is the calcivirus and that is the Norwalk virus. And question who having the history of uncooked shellfish in the older children will go for the Norwalk virus. So outbreaks is associated with the undercooked shellfish in the older children and astrovirus. Then we have the enterovirus, coronavirus, and the H1N1. So that is about the causes of the viral gastroenteritis, where rotavirus is the most common cause. Then we have the Norwalk virus, which is associated with the uncooked shellfish consumption in the older children. Coming to the slow virus disease definition, which a group of the viruses which causes the slow and the progressive neurodegenerative disease of the CNS with long incubation period and high mortality rate. So these are the slow viruses, which are the groups of virus which causes the slow progressive neurological degeneration, but with the long incubation period and long with high mortality rate. Characteristic is that they have the long incubation period ranging from months to years and predilection to the CNS. Immune response is either absent and contributes to the pathogenesis with fetal termination, slow growth rate, and genetic predisposition. In this, we have group A and the group B. Group A, slow viral disease, that is slowly progressive infections of the sheep caused by the lentivirus and the Wisna and the demyelinating disease of the sheep and the MEDI, that is the hemorrhagic pneumonia of the sheep. So that is the slow virus disease, mainly in progressive infection of the sheep and caused by what? Caused by the lentivirus. If you also remember, HIV is also the lentivirus family group member and causing what? Wisna and the MEDI in the sheep. Wisna is demyelinating and hemorrhagic pneumonia of the sheep. Then we have the very important one, that is the prion, that is the group B, and it is also an example of the slow virus disease where they have the slow progressive degeneration of the CNS with high mortality rate and long incubation period. Yeah, hi, very good morning. So the pathogenic mechanism is that it was discovered by the Stanley B. Prusnia, and the prions are the proteins, they are not virus. Prions are proteins without nucleic acid, and they are only pathogens without nucleic acid that are pathogenic. So prions are proteins without nucleic acid. All right. Now, normal prion protein, that is the PRPC, that is the prion protein presence on the chromosome number 20, get mutated to abnormal prion proteins and which accumulates amyloid plaques get deposited in the CNS. So, prion is also a slow viral disease causing the demyelinating degeneration of the CNS with high mortality rate and the long incubation period, and it is a protein and normal prion protein gets mutation resulting in the accumulation of the amyloid plaques in the CNS. Pathology, progressive evacuation in the dendritic process of the neuron, causing the astroglial hypertrophy and spongiform degeneration of the CNS. In the animals, just read the name of the disease that the animal are causing, that is enough, causing the scrapie and the mink encephalopathy. Then we have the BSC, which is the mad cow's disease. We also did a question yesterday on the special class about the mad cow disease that is caused by what? The prions, that is bovine spongiform encephalopathy. So we are talking about the disease in the animals, that are scrapie, mink encephalopathy, and bovine spongiform encephalopathy, that is what? Mad cow disease. Then we have the human prion disease with the Kuru having the tremors due to cannibalism. Then we are having the Georgeman, Strawbers, Schinkel's disease syndrome, that is a GSS, Georgsman-Straussler's Schinkel's disease, and the Creutzfeldt-Jacobs disease, that is a CJD, and the fatal familial insomnia. So we have the pathology in the animals as well as in the humans. In the animals, it is a staphymic encephalopathy and the mad cow disease. In human, Kuru, GSS, and the CJD and the FFE. FFI, that is a fatal familial insomnia. Symptoms are related to the CNS, that is the cerebral cortex. Then there is loss of memory and the mental alteration with visual impairment and the thalamus in the FFE fatal familial insomnia. That is what we have the insomnia due to the thalamus involvement. Then the cerebellum problems to coordinate body movement and difficulties to walk, that is in the Guru and the GSS, where the involvement of the cerebellum is there. Now then we have, apart from the A, B and the C, that is the group C, slow viral disease causing very important subacute sclerosing panencephalitis, which we also see as a complication of the measles, as a complication of the MMR vaccination. Although it is very rare, but whenever it will occur, it will be a very severe manifestation of the disease. Then we have the very important question one, that is the progressive multifocal leukoencephalopathy, that is caused by the John Cunningham virus. Okay, so that is the progressive multifocal leukoencephalopathy that is caused by the JC virus, that is the John Cunningham encephalopathy. Now we'll do the questions now. Yes, so that was is about the miscellaneous viruses. Now we also need to complete the HIV that we left in between. So we'll complete that. Questions about the HIV, we've already completed that, so we'll not go back to the PYQs of the HIV that we have done. We'll quickly complete the theory that was left. So, starting with the HIV. Now, HIV belongs to the lentivirus family, and it is of HIV-1 and the HIV-2. Okay, and we also have one more thing is that key belonging to lentivirus family, and the structure that are important is that uh, we have the structure and the non-structural genes. Now, structural gene are the N, gag, and the pool. Now, env will code for envelope protein, envelope antigens, and we have GP120 and the GP41. GP120 is the principal antigen, that is what? That is the spike antigen. Then we have GP41, that is a transmembrane particle. So that is the ENV gene coding for the GP120 and the GP41. Then we have the GAG gene that will code for the P18 and the P24, and the P18 is the shell, P24 is the core antigen. Then we have the pole gene, that is P31, 51, and the 66. Then we have the non-structural genes that are TAT, NEF, REF, VIF, VPO, VPR, and the LTR. Important one, remember TAT, that is a trans-activating gene that encodes for a protein that facilitates the transcription. And also it is not present in other families of the retrovirus. So this is important. Then we have the NEF, that is a negative factor. So it will down-regulate and control the viral replication. Then we have the regulator that will enhance the expression of the proteins. Then we have long terminal repeats which will promote, enhance, and integrate the signals. Now, we have the serotypes, that is a HIV-1 and HIV-2, and HIV-1 has the 40% of genetic variation, and also it is this HIV-2 has for genetic variation more, plus HIV one is more virulent compared to that of the HIV-2. HIV-1 is further divided into the MON, that is the major group, then O group, and then the new group. Epidemiology, there are 34.2 million cases, and India ranks the second. Now, this is what the important one, that is a GP120, GP41, GP18, and then we have the this P24, that is what the ANV, GAG, and the pole gene. Most common age group, we need to remember that most common age group is 15 to 49 age group, in which we further have 15 to 29 and 29 to 49 age group. And in this case also 30 to 50 age group has the maximum prevalence and has a maximum prevalence of 55%, and children under 15 years followed by the children under 15 years, that is accounting for just for 3% of the total cases. Okay, so that is the most common age group. Then we have the subtype A, that is most common in the world. Then we have the subtype A, B, and the C. Now C, that is in India, we have the subtype C, that is in India. Subtype C is common. All the serotypes are found in the Cameroon and the West Africa. Then high prevalence states, we need to remember the high prevalence states that are Maharashtra, Tamil Nadu, Andhra Pradesh, Karnataka, Nagaland, and Manipur. Mostly the South Indian and the North Indian states. Then, but when we talk about the drug induced that uh, needle induced transmission of the HIV, then we have to go for the Punjab, followed by the Delhi, then followed by the Maharashtra, and then Manipur. So this is what the highest states with that of the needle stick causing the transmission of the HIV. High prevalence states are the Maharashtra, Tamil Nadu, Andhra Pradesh, Karnataka, Nagaland, and the Manipur, and the needle induced are the Punjab, Delhi, Maharashtra, and the Manipur. First case in India was seen in the Chennai in the 1986, and the first case in the world was seen in the US, followed by the Paris, followed by the Thailand, and then India was the fourth country where the AIDS, this HIV case was found, and that too in the Chennai in 1986. antiviral retrotherapy should be started. Now, male to male sexual contact, that is the homosexual, has the highest risk of the transmissions. Now, receptors, there are that are receptors and the co-receptors. Receptor, any cell having the CD4 molecule, that is the T cells, and mainly the T helper cells, that is the CD4, that is the CD4 T helper cells. Other than this, we have the macrophage and the dendritic cell and the glial cell. Then we have the co-receptors, very important one, that is a CXCR4, that is the tropic strain. Then we have CCR5, that is CXCR4 and CCR5. Both the receptors and co-receptors bind to the GP120 molecule. Now we need to remember the count and where the infection rate is high. That is, one is the plateau phase, that is having more than 500 CD4 T cell count. Then post primary tuberculosis at 200 to 500, you mostly have the bacterial infections and the primary tuberculosis and the B cell non-Hodgkin's lymphoma and the CNS primary lymphomas. With less than 200, we have the mainly the fungal infection, that is the Cryptococcus, cytomegalovirus, and Pneumocystis carinii, with Kaposi sarcoma, that is HHV8, and Hodgkin's. With less than 50, we have the Mycobacterium avium intracellular complex. Now, coming to the next one, most common opportunistic infection, important one, that is by the TB, and most common opportunistic infection in the world by the pneumocystic aerobacilli. Now, WHO clinical staging of the HIV disease in the adults, clinical stage 1. Now, we'll come to the clinical stages of the HIV. So, that is starting with the first, that is the clinical stage 1, where patient will be asymptomatic, that is asymptomatic HIV infection with persistent generalized lymphadenopathy. So this is stage 1. So, WHO clinical staging of the HIV disease, including the stage 1, that is asymptomatic HIV cases with the progressive persistent generalized lymphadenopathy. Then we have the clinical stage 2, that is the unexplained weight loss, that is under 10%, recurrent respiratory tract infection with herpes zoster angular cheilitis, recurrent oral ulcers, papular pruritus eruptions, seborrheic dermatitis, and the nail infections. With clinical stage 3, that is unexplained severe weight loss, that is over 10%. This we have for to classify under the AIDS, we need to get the two major criteria and the one minor. Major criteria are the severe weight loss, that is the weight loss more than 10%, chronic diarrhea more than 1 month, with persistent fever more than 1 month. So these are important major criteria. Other than this, the minor criteria such as all candidiasis, oral air, leukemia, leukoplakia, pulmonary TB, severe bacterial infections, acute necrotizing ulcerative stomatitis, or unexplained anemia. Then we have the clinical stages 4, that is causing the wasting syndrome in the HIV, that is weight loss is more than 10% with unexplained diarrhea, fever, chronic cough, myalgia for more than 1 month. That is a wasting syndrome. With the pneumocystic aerobacilli and the recurrent severe bacterial infection, chronic HSV, and the esophageal candidiasis. So that we are talking about the clinical stages 4. Now, other than this, we have the extrapulmonary TB, Kaposi sarcoma, toxoplasma, HIV, extrapulmonary cryptococcus, disseminated non-tubercular, disseminated non-tubercular mycobacterial infections, progressive multifocal leukoencephalopathy with cryptosporidiosis, isosporidiosis, disseminated mycosis, recurrent sepsis, and the cervical cancer, lymphoma, and the atypical leishmania. talking about the lab diagnosis of the HIV, the first generation ELISA that uses the preparation of the HIV antigen. Then we have the second generation uses the recombinant. Then we have a third generation, the fourth generation using the synthetic oligopeptide and the combination of the recombinant and the synthetic peptides. Now, moving to the confirmatory, the exam test that we do now. First is the antibody detection. That is the Western blot test. Now, first is the antibody detection by the Western blot test using the whole virus lysate used by the NACO. Just a second. Hello, hello, huh, huh, huh. Sorry, that was a call from the department. It was urgent. Yes, I'm taking FMG. One is the image-based session on the 11th, and I'll take a schedule the important shorts like classes on the special class. I will update on the in the today's session in the evening. So I'll just let you know. Okay, and special class, follow me on that. I'll update on today's on the special class, so you will get the notification for the same for the FMG revision points, because FMG image session I've already scheduled, so you will get to know that. Now, immunofluorescent assay, radio immuno precipitation assay, then we have the line immunoassay, HIV RNA. This is the best confirmatory test. So please remember the best confirmatory test is what? HIV RNA. Now, then we have the P24 antigen detection and the viral culture for the co-cultivation techniques. Next are the surrogate markers that are CD4 T cell count we can take, or the hypergammaglobulinemia with the altered CD4 CD8 count ratio. Criteria used for the HIV diagnosis by the Western blot, there's two envelope bands, that is the GP41, GP120, 160 with or without gag, or the pole bands, and the CDC NE2, that is the GP24 or GP41. So what is the criteria that we use? What is the criteria that we use by the Western blot technique? WHO, that is involving two bands, that is the GP41 or either GP120 or 160 with or without gag, or the other bands, and CDC, that is NE2, that is the GP24 and the 41, or GP 120 by 60. Outermost, if you remember, we have 120, then we have the 41, then we have 18, then we have 24. That is either 120, either 41, or either 24. Now, narco strategy one is done for the screening of the donor blood banks. Then the strategy two is done for the surveillance epidemiological purposes, and the strategy 2B that is done for the symptomatic patients, and the strategy three that is done for the asymptomatic HIV patient. So one is done for the screening, 2B and 3 is done for the patients who are symptomatic and non-symptomatic, and for the prevalence, that is a stage 2A. Coming to the prognosis, now CD4 T cell count is most commonly used with HIV RNA road, that is the best marker and the most consistent. P24 antigen, and the B2 microglobin. Pediatric HIV, we have the HIV DNA that is most recommended, and the HIV RNA detection with 24 antigen and the ELISA. Diagnosis in the window period, initial time when the antibody detection methods are negative, roughly it is around 2 to 8 weeks. Window period is around 2 to, so window period, which is around 2 to 8 weeks. All right, and it is can be as low as 22 days when third generation antibody detection kits with high sensitivity are used. P24 antigen detection that detects only the after the 16th day. All right, so we have the window period that is around 2 to 8 weeks where the antibody is not detected, and but the P24 antigen can be detected by the 16th day, and HIV RNA by 12th day. Therefore, HIV RNA is the most sensitive method to for the detection of the AIDS. So that is about the window period, that is 2 to 8 weeks. We do not see the antibodies, but we get to see the HIV RNA on the 12th day and the P24 antigen on the 16th day. Then what are the guidelines for the post-exposure prophylaxis? That is the body fluid considered at the risk, blood genital secretions, and the CSF body fluid not considered at the risk. So, what are the guidelines for the post exposure? Now, if the body fluids that are the blood or we have the genital secretions, CSF, they will be considered as the risk factors, but tears, sweat, saliva, and the feces, they are not the risk factors, and post exposure prophylaxis should be started within 2 hours only. So, occupational HIV post-exposure prophylaxis, that is administer the first emergency dose of the PEP medication with the exposed site management. That is, if the source HIV is not known, then obtain the consent of the source, perform the HIV antigen antibody detection test, and do the screening. If source status are not known or if the source is not available, obtain the consent and perform the testing for the antibody HCV screening. Then source is known by the medical record to have HIV. In that case, 28-day course of the post-exposure prophylaxis is indicated. The exposed person should be completed 28 days course of the PEP with the recommended regime, and all the medications are taken by the mouth. Then source HIV test results in the negative. Source has had exposure to HIV within the previous 4 weeks. Yes, then perform the HIV RNA assay. If it is negative, then stop PEP. No need of that. If it's positive HIV RNA, then we go for the 28-day course of the PEP. Source is not available, does not have the capacity to consent to refuse HIV testing. In that case as well, we give the 28 days course of the PEP. Then we have the evaluation. Then we have the evaluation of the HCV exposure risk. That is, source is known to be HCV positive and is not available. Check the exposed individual HCV RNA ALT baseline at week 4 and 12. If the source is available, and test for HCV antibody. If it is positive, check for the HCV RNA. If it is positive, check the exposed individual RNA and ALT at the baseline. And if it's HCV RNA is positive, no follow-up is needed. Source is HCV antibody negative, then assess the risk. Risk is low if source had no high risk exposure to HCV within last 6 months. If we had the exposure within 6 months, then the high risk. In that case, we'll go for the antibody test, HCV RNA test. If it's negative, then no follow-up is needed. And if it is positive, then we'll expose individual will go under 4 to 12 weeks of post-exposure prophylaxis. At week 12 post-exposure, check HCV antibody as well. So that was it. That was a short session of just half an hour. So thank you so much, and do use my code, that is Muskan 10, to get 10% of the discount. And I will see you soon in the next class, and we'll cover the RO virus in that case, because that is the only virus we are left with. Then we'll end the virology, and we'll cover the quick revision sessions for the FMG within 2 days. Alright, so take care and do press the bell icon and do like, share, and subscribe. And I'll see you soon. Take care and bye bye.